And our final speaker for this session is Dr. Michelle Coe. She was already speaking this morning. Dr. Coe is an associate professor in Canada, or Tier 2 Canada Research Chair at McMaster University. She's a physiotherapist by training, and my co-lead for Team 3, the Rehabilitation and Recovery for Sepsis Canada. I love working with Michelle. We meet every couple of weeks, and I've learned so much from her. She is the principal investigator for the CYCLE study, which is using embed cycling for critically ill patients. And if you want to talk to somebody and gain some insight about in doing a study with a complex intervention, talk to Michelle. She's a wealth of knowledge. So her title of her talk is Improving Access to Sepsis Clinical Trials. Dr. Coe.
Thank you very much for this opportunity to think about a really important question. And I'm also grateful for Sepsis Canada to give us the opportunity for Gordon and I to work together, because we're learning a lot, and more importantly, we're learning from patients. So this is really important for advancing research. So here's a brief overview of my talk today. First, why is it important to do sepsis trials? Are there risks and benefits of being part of a clinical trial? I'll provide a Canadian case study that builds on Marie-Hélène's work. And finally, provide a bit of a vision for what I would love to see, and for all of us to see, in terms of clinical trials in the future. So why are sepsis trials important? First of all, I want to challenge your thought about what a clinical trial is. Hands up if you have a drug trial. Is a drug trial a clinical trial for sepsis? Hands up? Okay. Next, hands up if you think a rehabilitation study could be a clinical trial for sepsis. Oh, good. Hands up if you think that a PET-assisted therapy study could be a clinical study for sepsis. Yes. So you're a very enlightened audience, because all of these things can be considered clinical trials. So I'd like you to think very broadly about the concept of clinical trials. What we know from sepsis survivors is that after we interview them from a hospital stay, we've got opportunities for improvement. What you see here is a study of a survey of over 1,700 sepsis survivors, and the authors asked them, what did they think about their care post-hospital? Anything in blue represents something that they either did not receive or could not remember. So this is everything ranging from being told what sepsis is, receiving psychological counseling, either in the hospital or after the hospital, receiving any type of therapy in the hospital, and having social services support after the hospital. You'll note that in yellow, people were either somewhat to very dissatisfied. So we have a lot of opportunities for improvement. And Dr. Prescott and colleagues wrote a very compelling review about thinking about enhancing recovery after sepsis. We heard this from the panel yesterday, and how important it is. And what I'd like you to note here is that this is, on the dotted line, your baseline health. Anything above the dotted line is better health. Anything below the dotted line is worse health. And you can imagine someone who has a sepsis admission, you're noticing that their health declines at the onset of sepsis. It's worse when they're hospitalized. It starts to get better as the acute sepsis episode resolves. It starts to perhaps not flatline. I don't want to say flatline, because that's not really, starts to plateau as you're recovering. And you're looking at overall recovery and long-term outcomes. What is the bigger picture? Can we improve outcomes so that we can exceed better health for sepsis survivors? And this is really important, because sepsis is more than surviving. This is a cohort study that looked at measures pre and post sepsis. So before people had sepsis, they took measures on cognition. You'll notice that these dark bars represent moderate to severe cognitive impairment. And if you think about function, you'll notice that these measures represent the limitations in function at baseline. This is all pre-sepsis. What happens post-sepsis? You'll notice here, these dark lines have increased. We have more people with moderate to severe cognitive impairment. Similarly, post-sepsis, more people have more functional limitations. We need to be thinking about life after sepsis. Something else to note. Did you know that, for some reason, females get worse sepsis care? Fewer females had completed sepsis bundles. For females, they had a longer time to starting life-saving antibiotics. Fewer females also received life-saving therapies. We need to try to understand the reasons for these disparities. We say that the answer to this is through a clinical trial, but what are the risks and benefits? Certainly, Marie-Hélène talked about some really important concepts from a research coordinator perspective. And certainly some of the risks of participating in a clinical trial could be that you could experience side effects. It could be inconvenient for the family members or for the person enrolled in the trial because there are several measures, maybe an extra blood draw, which is painful. And there's also a potential risk of breaching confidentiality. But what are the benefits? Something to know is that if you have a clinical trial funded in Canada, this is the top 15% of all research. It is so hard to get a clinical trial funded in Canada. A clinical trial is highly vetted. It also has to go through ethics approval, and the Research Ethics Board will carefully review the inclusion and exclusion criteria and all of the trial procedures. A benefit of clinical trials is that you have access to new therapies. You have another set of eyes looking after your loved one. So you have research coordinators and investigators carefully collecting data about your sepsis stay. And really, this can improve treatments for future people who become infected with sepsis. What does the evidence say? This is a really tricky area to study. So what would happen to someone who is eligible for a clinical trial and is enrolled in a clinical trial versus the same person who would be eligible for a clinical trial but then is not enrolled onto a clinical trial? Are there any benefits for actually being enrolled in a clinical trial? Because you could get randomized to the control group. Maybe the control group is less beneficial than the intervention, or vice versa. Maybe you're enrolled into the intervention, which could be harmful. But overall, is there any benefit for being in a clinical trial? And what this is a study that looked at 6 systematic reviews and almost 300 randomized clinical trials. And what they found overall, there were over 380 comparisons of benefit for being in the clinical trial or not. In terms of participation benefits flat out, this arrived at about 17%, where you're definitely advantaged by being in a clinical trial. 10% of the time, if you were enrolled in a clinical trial, this is represented by the lightest bars, it was not beneficial. or there was not a benefit for being in the trial. However, 90% of the time, there was no difference. So in total, if you consider participation and no difference, 90% of the time, there is not a disadvantage for being in a clinical trial. So what would you choose? Being in a clinical trial where you could receive the intervention of the comparator. This is a protocol that's been highly vetted. It's very difficult to get funded, or usual care. So what's a Canadian case study? So what we wanted to do was share with you further information from the Canadian Clinical Research Network. As Marie-Hélène described earlier, we conduct information and collected information about CIHR-funded studies for COVID. We also collected information about different hospital sites across Canada, and that's the map that Marie-Hélène showed you earlier. We invited these multi-center government-funded studies to share information with us about their study characteristics and real-time recruitment. Only information about whether someone was enrolled in the study, not study results. We also invited hospitals to share with us information about their research infrastructure. These data were collected by expert research coordinators who had a lot of experience understanding both clinical trials, but also working with different hospitals. These data were then entered into the CCRN database and further analyzed. So what did we find? Out of 26 government-funded CIHR trials, 22 agreed to share their study characteristics and real-time enrollment. Remember that real-time enrollment does not breach any confidentiality. This is simply understanding the number of people enrolled in a clinical trial. We identified 419 hospitals and 200 shared information about research infrastructure with our team. So what happened with the COVID studies? Of the 16 randomized trials, 78 hospitals across Canada enrolled over 3,800 patients into COVID studies, of which 31 patients were randomized per site. The values in brackets represent the interquartile range. So some studies were as low as 25 percentile, would be 10 patients to 61 at 75 percentile. Of 6 observational studies, 62 hospitals participated, enrolling over 25,000 patients. The median number of patients enrolled in these observational studies was 155, with a range of 46 to 348. 97 studies reported recruiting, and on average, at a site, there were 2 COVID studies. The full-time equivalent of research coordinators was about 1.3, but 75 percentile is 5.5. 35% of sites enrolled outside of business hours, and 55% had opportunities for deferred consent. So you can see that there are opportunities to enhance our research capacity across Canada. Here is an overview of where the research occurred in Canada. And as Marie-Hélène identified earlier, blue dots represent hospitals where research is not occurring. Red dots represent research in hospitals where research is occurring. And it is wonderful to see involvement from community research sites. This graph represents Canadian hospitals as a proportion of the total number of hospitals in Canada by province. The orange bars represent each of the individual provinces and what proportion of hospitals are represented in Canada. The gray bars represent the percentage of hospitals that were recruiting to clinical studies for COVID. And you can see that there is some overrepresentation by Alberta, BC, and Ontario, whereas there are some places in our country where there isn't any recruitment occurring at all. We further looked at clinical trial enrollment. So this is specifically limited to the randomized trials by hospital. And what's interesting to note is that 13 centers accounted for 50% of all randomizations into these COVID trials. But if you start to look at the data that's normalized to hospital beds, you can see that there are some hospitals that are punching above their weight for enrolling patients into clinical trials. So this is a starting point. As Marie-Hélène said, in order to understand how to improve clinical trial access, we need to first measure what we have. And this is a paper that's currently under review. So what's a vision for future sepsis clinical trials? This is a paper that Prescott and colleagues published in the American Journal for Respiratory and Critical Care Medicine. And their vision was for people who are sepsis survivors, they would be entered into a local or global registry. Then this registry would help inform education for patients and families. It would help inform emotional support for patients and families. It would also help set priorities and also be a conduit for enrollment into cohort studies or clinical trials. And something like this would be fantastic because then we could have a global understanding of sepsis. But I think many of us in the room have a grander vision. What would happen if we were to embed research into our Canadian healthcare system and include all patients with sepsis? Because we need to understand about more than the survivors. If we were to immediately enroll someone into a cohort study, we would learn something from every single patient. Then, after cohort studies, identify potential randomized trials that could be across the continuum for patients with sepsis. We would continue to include education and compassionate care across the patient's journey, and we would continue to learn, just like the model proposed by Prescott and colleagues, but we would then use that for priority setting. What's a vision for the future? Wouldn't it be fantastic if every single Canadian had access to a clinical trial? We can see what the potential is here, and is there an opportunity for us to do that? Thank you.
So, Michelle, this question may not be exactly for you, and maybe it's for Melissa and Marie-Hélène at the same time. It's actually from the audience, and so we do have some online people, and I think, I'm not sure if it's from Shirley or Marie-Josée, but, or José Champagné. How can we standardize what the RIBs allow as part of studies for blood volume? So the comment is, and this is where we get into some challenges for REBs, the volume that's allowed between REBs, even within Ontario for blood draws, is different. And so I was thinking about Melissa's comment about the CHEERS program in terms of blood volume draws and how we standardize that across the country.
Maybe quickly answer that, and then I actually have a question for Michelle. It's really interesting because in pediatrics, you'd think that the REB would know how many trials are actually collecting biospecimens and how many trials are actually running in a unit at any given time, but that's highly variable. And so there's no restrictions, actually, I know in our unit on the amount of blood that could get drawn, say, from a neonate, which is kind of crazy. So that actually gets controlled at the investigator and the unit level. But in other places, it's quite different. So I would say there's no standardization on that, at least in pediatrics. I don't know if somebody else wanted to speak to adults, but, and then I'll ask my question to Michelle.
It's a really good question, and I wonder if that's something that we could actually start to capture. It becomes very tricky trying to understand the different REB by study, but I wonder, Marie-Hélène, if that's something we could potentially look at to see what the restrictions are. So that could be something that could be we can discuss a bit further about understanding, at least from the investigator's perspective, what have REB said about volumes for blood draws.
And of course, it's further complicated in pediatrics because 2 mils in a neonate is not proportionally the same as 2 mils from an adolescent. So, if I may, my question for you, Michelle, was a very, very long time ago, we put in a funding application to actually try and get funding for a sepsis registry. And the discussion around that at that time, which is a number of years ago, was a lot of complexities around the line between data collected under the auspices of quality improvement and then later leveraging that data to be used for research purposes. That's very dicey in terms of you can collect data for quality improvement without consent, but then using that for other purposes or to inform research. Canadian Neonatal Network, I think, got started before people started being picky about things like that. But I think it's harder and harder to do, so I'm curious if there's been discussions about that.
That's such a great question. And if we're trying to think about trying to improve outcomes for patients, we have to have an unbiased sample. So how can we go about doing that? And I think it could be important to look at other models. Do we look at cancer registries? Do we look at trauma registries to understand how we can get this unbiased sample so that we can study people, and how we can link some of the data? Like how can we go about doing this? Because even in COVID, we had to understand more about this disease that was unfolding in front of us as a public health imperative. I'd be curious if other people have other ideas, because we know we also have these large-scale administrative databases. Can we link some of that data together? Because is that a way to better understand sepsis? The other thing is that for anyone who's been enrolled in a clinical study or a clinical trial, can we have permission for recontact so that we can do longitudinal follow-up, so that the trials all work together, and we could then have a large inception cohort of patients where we are doing standardized follow-up at specific time, because we're following up. We have this obligation to the people who have agreed to be in our studies to follow up and understand what's happened to them longer term